All right, so localized prostate cancer. So there's a few different points at which we're conflicted, where we're sitting on the fence, right, where the patient or the urologist or perhaps a radiation oncologist sitting on the fence trying to decide what to do. The complexity in that decision for surveillance versus treatment. The question about should you treat at all? Should you go to prostatectomy? If the patient's had a prostatectomy, do you consider adjuvant or salvage radiation therapy? And of course, there's a variety of tests that can be used in these spaces. And so much of the difficulty with this comes to do with the broad spectrum of disease. Patients take vastly different clinical courses, but also the relatively long natural history of the disease, right, which is why patients struggle. One of the inconsistencies in cancer treatment is the earlier stage of disease, the harder the conversation. The late stage disease, the conversations actually end up being very straightforward. So it's this question of to treat or not to treat, and I'm going to focus on kind of two scenarios. That question of active surveillance versus treatment for the Gleason 6 or perhaps the 3+4 patient. And then that scenario of the prostatectomy with adverse pathology for surveillance versus active or adjuvant radiation. And, this is a situation where, you're a calf sitting on that fence trying to decide which way to go, right? So this is all about overcoming indecisiveness, right? Let's get you off the fence, push you one way or the other. It's easy. All you need to do is order this test and it answers all your questions, right? All right. So there's a variety of tests now, right, for who to biopsy, when to rebiopsy, who to treat, who to follow on therapy. And we're not going to go through them all. We've only got a few minutes to talk about this. But the principles of how we should evaluate these tests really are the same. Right now, no biomarkers are routinely used. Most of them are used in only a small minority of patients. You get some inconsistent methods. They're all slightly different, right? Slightly different specificity. And they're really all based mostly on retrospective studies, underpowered studies for the most part. And of course, the ability to run these tests are going to be limited by your tissue availability. The legitimacy of the data sets is somewhat limited by single or maybe 2 or 3 institutions being involved and lack of validation sets. And then there's some heterogeneity about states being looked at, biochemical recurrence, or is it persistent, PSA post-op, which of course are different populations. But there's a lot of optimism here, right? You have molecular understanding of disease, but the problems, of course, are statistical significance doesn't necessarily equate to clinical significance. Does it actually matter to the patient what you're telling them? And of course, technical validation of a test showing it does what it says it will do doesn't equal clinical validation, which is to say it does something actually useful. So we have rules of evidence where, in every scenario there's rules of evidence. Dr. Carlson talked about it in terms of kind of 5 golden rules, and there's golden rules really for each stage of disease. So there's confusion. This is one of the problems with having a lot of tests and a lot of options. Options are what give patients a hard time. They focus when it's nice and simple and you can tell them exactly what to do. So there's confusion because there's overlapping clinical spaces. There's tests that are assessing fairly similar molecular phenotypes. There's aggressive marketing, right? Patients are told from all of these well-meaning people around them that they have to have this, that, or the other test. Everyone has an opinion. And then there's the expectations. People love a number on a piece of paper because a number means something, right? Look, I'm 0.65. That definitely means I need to be treated, right? Right? Okay. So patients think we're improving outcomes, which is true if anxiety is the target outcome. Okay? All right, so we have a lot of products available. I'm just going to focus on these 3, and again, in kind of just in general sense. Decipher gives you a prediction of distant metastases after surgery. It certainly outperforms just clinical scores like the CAPRA. You have the Oncotype DX, which combines clinical parameters with the GPS, and the CAPRA score does a better job of a predictor of high-grade or high-stage disease or biochemical recurrence. You have Prolaris, which can be used in a couple of different settings. Again, is an independent predictor of things like mortality, of biochemical recurrence, of metastasis. and it can be combined with clinical criteria like CAPRA. So that's perfect, right? That's all you need to know because these things answer all your questions. I like this slide because he reminds me of Canada, you know. They're all brave when they can hide behind their big brother. Okay. Okay. All right, so let's talk about the Decipher test. Right. All right, so the Decipher test, this was developed by our colleagues here at Mayo Rochester, Jeff Carnes and team. And they did a case control blinded validation study looking at a cohort of patients up at Mayo Clinic Rochester. Most of these patients are curatively treated. 400 of them had biochemical recurrence, 73 developed metastases. Looking at this cohort, the 3-year biochemical recurrence rate is about 27%, metastasis rate about 7%. Okay, and they looked at high-risk patients. And just looking at the ROC curve here, without question, the genomic classifier outperforms any of the standard familiar criteria, clinical criteria we've been using for years. We look at the cumulative incidence of metastases using these cutoffs. So the 0.6 is a high-risk group with the GC score, then the mid group, 0.4 to 0.6, and the low group of 0.4. And there's a clear separation here. I mean, this looks really good, right? Except you have to remember, it's only 22.5% of high-risk patients having METs at 5 years. And even in the low-risk group, you still have a couple of percent of patients, 2.5%, having METs at 5 years. So unfortunately, even though there's a difference between these two groups, over 75% of patients will have no METs, even with the high-risk score, and you're still going to have this group of patients, this heterogeneity, even with a low-risk score developing metastases, right? So it's not perfect, although your patients probably think it is. Genomic classifier absolutely outperforms, you know, the standard metrics we're used to. But this slide, and then this comes from Dr. Carnes, you know, look at this now. With your GC score, if you have this high score, red dots are metastases, blue are patients with no metastases. You have Gleason score on the bottom. So there's some correlation between GC score and Gleason score, but even with low GC scores, so less than 0.6, you still have a lot of red dots, and above 0.6, you still have a lot of blue dots, right? So again, making this point, patients think you're giving them an absolute answer. I'm in trouble or I'm not, and it's that false sense of security because it's really not that clean. This is a continuous variable. It's higher or lower. It is not yes or no. And so there's a lack of understanding usually in our patients about how this really works. Few seconds, so I'll move more quickly because you've seen this data. This is another validation set for the Decipher. This was 2 institutions, Thomas Jefferson and Mayo. Unfortunately, this box didn't transmit well, but only 10% of patients in this data set ultimately developed metastases, so fairly low. Again, the ROC curve looks very good. Reclassification of risk. This is really the main point that gets talked about, right? If you use CAPRA alone, you have one distribution of risk. If you add any of these scores to it, in this case to GC, you get some redistribution. You take some patients who were high, you move them to low. Okay, they feel good. Patients who were high tend to stay high, but you get more accuracy, at least better accuracy throwing darts. And I'm not much of a dart thrower, Colonel, but you're a little bit more accurate if you take the blindfold off. Fair enough. Okay? All right, so just showing that GC is better than CAPRA. And then, again, you know, you talk about what do we prove with the other tests, not to spend all our time on Decipher. With the Oncotype clinical utility study, this was demonstrating that change in decision-making, okay? People on the fence decided to tilt over towards doing surveillance, or people who thought they weren't going to do surveillance said they would. Again, Oncotype DX, reclassification of disease. Polaris, same thing, right? The same type of data, really, from the 2 clinical utility studies. It focused on change of management. You thought you were going to do one thing, you decided to do another. You know, when patients get a second opinion, they probably have 65% change in management, or when they go from one, you know, urology to radiation oncology and back. But you have more active surveillance patients, and that's certainly a good thing, if you're not able to decide on active surveillance in the first place, certainly. So in summary, these results by these biomarkers are expressed as a percentage of risk, but it can lead to misinterpretations. Patients don't really walk away understanding, I can be low risk and still have a bad outcome, or vice versa. These are continuous variables. They're often presented as being dichotomous. The biological markers, without question, should still be used in combination with clinical markers. You know, for the most part, who the bad patients are. You know that from experience. You know it when you see it. There's only a few exceptions. But what we lack, and I mean, this is the real point, we lack prospective studies really proving the cost effectiveness, even though the back of the napkin does work well. The fact of the matter is that the landscape is constantly changing. The cost of tests, the cost of workup is constantly changing. And the problem with these retrospective data sets is most of them were collected on patients from, say, late 90s or early 2000s up to maybe the mid 2000s. So if you're still practicing medicine the way you did 15 years ago, then these tests are probably a good thing. But now you live in an era where you have advanced, 300 megahertz ultrasounds, you got advanced imaging, you got better treatments available. We have choline, PET CTs, PSMA, other things that can detect the microscopic occurrences that BCR was hiding before, right? So do these tests have any applicability in the modern era? The answer is truly we don't know. So the available biomarkers are not proven to improve long-term outcomes. We don't have a single data set saying you reduce mortality or that you reduce ultimate suffering down the road, aside from the acute phase of the treatment being offered at that moment. And these tests really focus on testing a pelvic organ to treat supratentorial disease. Mostly what you're doing is decreasing decision-making anxiety. Patients can't decide what to do. You could probably guide them in the first place. And you talk about saving money, we could save a lot more money on top of just shifting patients over to active surveillance if we don't order the test in the first place, and urologists would just go ahead and tell the patient what to do without being so namby-pamby about it. So what y'all need to do, quite simply, is, thank you.